Today to introduce Dr. Sidra Jahangir, who is a consultant colleague of mine. She's got a special interest in gynae pathology, in hepatobiliary pathology, and also cytology, particularly hepatobiliary cytology. She's spoken on the Pathological Society Winter School on this subject. So endoscopic ultrasound biopsy of pancreatic samples. She's been in our hospital now for 3 years, previously worked in India and Saudi Arabia. Very grateful to have her. Also, just before I forget, and to make sure you all know, but I'll repeat it at the end, we will be having a summer break and recommencing on the 3rd of September at the same time in whichever territory you are in. The time may change in the UK, but the time in your territories will remain the same. So same time, Wednesday afternoon, we will be resuming on the 3rd of September, and we have a full program again already in place for the next academic year starting in September. So please feel free to share the links freely with all your colleagues wherever you are. And so without further ado, over to yourself, Sidra. Thank you very much.
Thank you so much, Richard, for your kind introduction. Just a little correction. I completed my training and start practicing in Pakistan, and then I went to Saudi Arabia, Riyadh, and this is my current place, Manchester.
I'm very sorry.
No, that's perfectly fine. So I'm very delighted and really honored to present this teaching session and lecture on this forum. Thanks to Diagnexia, Richard, Winter School, everyone for giving me this platform. Okay, so the topic is pancreatic EUS FNB. These are very crucial and important diagnostic modality by which we diagnose pancreatic pathology. Before we crack on with some of the cases, just a brief overview how the procedure is done. This procedure was introduced in early 90s, and there is an ultrasound probe attached to the endoscopy probe, and through the ultrasound guidance, gastroenterologists can see and target the lesion within the pancreas, either it is head, tail, or body. And through that ultrasound guidance, they are inserting their FNA needles and core biopsy needles to get the diagnostic material. This is just, I'm sure you are already aware about the normal histology, but just to wrap up before cracking onto the pathology, this is the normal histology of pancreas. It's a nice lobulated architecture of acini, ducts in between, and some neuroendocrine clusters, islet cells. So this is normal histology, and histology, knowing the correct histology is very important to pick up the correct pathology, I believe. So this is our first case. Case number 1, 67-year male, presented as a mass in pancreatic tail, large mass, 6 centimeter. Patient is very symptomatic with obstructive jaundice and nausea, vomiting, and all the abdominal pain symptoms. And this is how we get, this is usually the material looks like through FNB. It's a thin worm-like course. And if you can appreciate, we don't see any normal pancreatic tissue in this focus. This is a low power view. And you can appreciate this tumor infiltration within the stroma, some stromal reaction, desmoplastic changes. And if we go to the high power, the tumor is kind of monotonous looking. You won't be appreciating a lot of pleomorphism. The cells are round to oval with kind of moderate to abundant cytoplasm, uniform looking nuclei, further high power. You can appreciate that these discohesive cells have abundant eosinophilic cytoplasm, and some ribbon-like arrangements here and there. So the morphology is not very classical for ductal adenocarcinoma, which is the commonest tumor in pancreas. But considering the monotonous lesion, there are few differential diagnoses which always be there and like included in your differential diagnosis list. It could be neuroendocrine tumor. Second is solid pseudopapillary, but then again, it's more common in female patient. Acinar cell tumor, and another important differential diagnosis is always a lymphoma, plasmacytoma, or hematological malignancies, which can be presented in any organ of the body. So we threw just few immunos and special stains. Started with CK7. CK7 was negative, very patchy, very weak positive. Morphology is not that characteristic for adenocarcinoma, so we are also thinking on other lines that this is something because radiologically it's an aggressive looking 6 centimeter mass. So we are also considering other malignant diagnosis. PS stain was done and it shows a positivity in cytoplasm. You can appreciate this positive stain, magenta sort of color or a dark pink color staining in the cytoplasm. And when we did DPAS, this is very like eye-catching that the material is not glycogen and it stays there on DPAS stain, diastase. So it's a diastase resistant material. And I'm sure with this slide, you are about to get some idea like what we are dealing with. So monotonous tumor, aggressive, radiologically large tumor mass with PAS and DPAS positive. This is CK7, which is almost negative for us. We did a couple of other immunos, including Melane, beta-catenin, CD117. These stains were also negative. So our favored diagnosis on basis of clinical information, radiology, and morphology and immunoprofile is the acinar cell carcinoma. The patient was very much like symptomatic and it presented in an A&E with acute symptoms. So the moment we gave this diagnosis, they rushed for the resection, the HPB surgeon, and further immuno we have completed diagnostic marker on a resection specimen. So acinar cell carcinoma, it's a rare pancreatic tumor, but you do see infrequently. This is an aggressive malignancy, which shows acinar cell differentiation, and the diagnostic marker for this entity is CD10 and trypsin. Sorry to say, both stains were not available in our lab, but we have to outsource for these 10, and it will take further few days to get back the slides. This tumor is more common in male patient and usually present in late ages after 50s. And rarely, very rarely, we can see acinar cell carcinoma in children. There are just few case reports. Most common site is head of pancreas. CT and MRI will definitely tell us it's a malignant looking mass with heterogeneous enhancement. Prognosis is slightly poorer as compared to like a common ductal adenocarcinoma and pancreas. Acinar cell carcinoma behave more aggressively. And it's sometimes it's purely a solid tumor and you can have a cystic component in it as well. So this is how a CD10 and trypsin stain looks like. The both shows a similar kind of like granular cytoplasmic staining. And these two stains are very specific, sensitive and specific for this entity. And whenever you have this entity in your differential diagnosis, either one of them should be done for the confirmation of diagnosis. So case 2. Again, male patient, head of pancreas, mass in head of pancreas, and this is the FNB material. A very nice, long tissue core. You can clearly appreciate you don't see in this core at least a normal pancreatic lobular parenchyma. If you focus on at this area, I don't know if you can appreciate my arrowhead or no, there's little normal pancreas with some chronic inflammatory reaction here. But this core is diffusely infiltrated by these malignant looking ducts. No acini. Stroma, pancreatic stroma shows very nice desmoplastic reaction, juicy stromal changes. Another view from the same case. So if you concentrate on this focus, there is a normal pancreas, and you can identify the lobule, one lobule of pancreatic tissue where the multiple acini are arranged compactly. Again, some benign ducts here. This duct is also benign with some reactive changes, but if you focus on this ductal group, you can clearly appreciate there is a nice internal control that the nuclei are enlarged. They have lost polarity from the basement membrane. The nuclei are significantly large, vesicular. Some chronic pancreatitis element here, which is very common in when the tumor is growing and expanding. The junctional area between the tumor and pancreas show chronic pancreatitis-like changes. And the main lesion can easily be missed if the endoscopist or gastroenterologist are not hitting the correct area, and whatever, like most of the time, what you are getting is the chronic pancreatitis element. So here there is a tumor here, ductal adenocarcinoma, no acini, the lobular architecture is gone, and some chronic pancreatitis element here. So again, a high power view of the same thing which I mentioned earlier. This is a malignant duct, poorly differentiated adenocarcinoma focus here, and some normal pancreas you can appreciate here with pancreatitis-like changes. So this is again same the diff quick slide and Gimza stain prepared on site from the same case and same patient. DIFQuick, also called as a Gimza stain, is very good stain to assess the adequacy of the material. So, and it can be done very quickly within the same area in the gastroscopy suite. And most of the time we are using this stain to give a rapid on-site adequacy, which is also called ROSE. So malignant ductal groups, Staghorn-like clusters. You can clearly appreciate big, large nuclei, haphazardly arranged, crowded ductal cells with all overlapping hyperchromasia, pleomorphism, single isolated cells. All the features which required for the diagnosis of adenocarcinoma are there. So this is a cytology smear slide from the same lesion. So pancreatic ductal adenocarcinoma, I'll just briefly go through some theoretical and practical diagnostic details on this entity. More than 90% of the neoplasm in pancreas are pancreatic ductal adenocarcinoma, aggressive malignancy. Although we have now targeted therapy available, but still morbidity and mortality rate is still high. Usually patient present late at the later stage when the disease is already advanced. So you have pancreatic ductal element in this tumor, stromal reaction, desmoplastic stroma, and some necrotic areas. The precursor lesion for this malignant tumor adenocarcinoma could arise from the PANN, pancreatic intraepithelial neoplasia, or IPMN, intraductal papillary mucinous neoplasm, or it could arise from a mucinous cystic neoplasm. So these are generally the general precursor lesion for this malignant tumor. Head of the pancreas is the most commonest site, followed by body and tail. Etiology, there are certain environmental factors and there are some genetic syndromes and mutations which can trigger the tumor formation. So smoking, alcohol, obesity, high intake of dietary saturated fat, chronic pancreatitis, and diabetes, these are the some common risk factor. And some syndromes, most common are like Lynch syndrome, FAP, familial adenomatous polyposis, and Peutz-Jeghers syndrome are the common syndromic conditions. Most of the time, patient present with backache, weight loss, jaundice, diabetes mellitus, malaise, rapid weight loss. If you do serum test, CA19-9 and CA, in most of the cases, not all cases, but in most of the cases, you find raised in the serum. CT is very characteristic, give us a very useful information, whether it's a benign or a malignant thing, or so it's sensitive about 92 to 95% of cases. Double duct sign is a very characteristic sign for pancreatic ductal adenocarcinoma, in which you can see the dilatation of both biliary and pancreatic ducts. Prognosis depends on the stage, morphology, extent of disease, and nodal involvement. Again, it's a part of stage. So the smaller the tumor, less lymph node involved, it's a favorable prognosis. Extra pancreatic extension is a bad prognostic sign. Histological grade is also very important, and if it's a pure ductal adenocarcinoma or there is like or mixed component, that will also affect the prognosis of this tumor. So these are some common variant, like adenosquamous or a pure squamous cell carcinoma. You can see pure squamous cell carcinoma also in pancreas, colloid carcinoma, hepatoid, medullary, invasive, micropapillary, signet ring, undifferentiated, and undifferentiated with osteoclast like giant cell. Two type of undifferentiated carcinoma there. These are like some beautiful variants. I'm calling this beautiful, but they are very difficult sometimes to diagnose on a smaller biopsy. And I think some patterns are very favorite for exam point of view. Although morphology is characteristic, but if you are dealing with some variant, suppose signet ring cell variant or any poorly differentiated tumor, you need to apply immunos for the confirmation of diagnosis. So loss of SMAT4 or also called DPC4 is also characteristic for this tumor. CK19, CK18, 7, and 8 are usually positive in most of the tumor. Molecular are also very important for our oncologist, and there are some targeted therapies available against these molecular alterations. So KRAS, MSI, BRAF, BRCA, RET, and RF1 are the most common molecular alterations found in ductal adenocarcinoma of pancreas. And it's very important. Previously, when the EUSFNA was introduced in 90s, it's only started with FNA, like smear slides only. Later on, gastroenterologist and the GI team moved to take a biopsy as well along with the smears. And now the current practice is that like most of the advanced center labs, they are putting everything for a cell block and in formalin to preserve each and every cell, because considering the importance of molecular now, because for molecular studies, we need to have tissue. We can't do molecular studies on cytology smears. So FNB is now the part and parcel of EUS FNA, and we always getting a nice thin tissue core, but the tissue should be there, lesional tissue should be there to perform molecular study, and of course ancillary studies, including special stains and immunohistochemistry. Case 3, again, male patient, mass in head of pancreas. So you can appreciate from this low power how precious the lesional material is. This is a like day-to-day scenario. Most of the time what we are getting is either the GI contaminant epithelium from stomach or duodenum, depending upon the approach gastroenterologist is using, or a lot of blood and fibrin along with the tumor cells. So we have to triage and handle this material very carefully, not to waste anything. So among the blood and this fibrin clots, we have these tumor areas. So again, this tumor is also very monotonous looking. Some organoid structure like ribbon-like strands are there. So if the tumor cells are making some patterns and arrangements and showing some sort of structures, then lymphoma is like unlikely. Slightly reduced on the bottom, and you can push that differential diagnosis and lower down. So here you can appreciate some arrangements, some cords and ribbon-like arrangements, some discohesive cells here and there. They are again very monotonous looking, mild cytoplasm and very clumped nuclei. Sorry for this is the highest power capture. I can take it from the virtual slide, but on the microscope, the salt and pepper chromatin is very nicely appreciated, but somehow it's fainted on this slide. But there is salt and pepper like chromatin. You don't see open nuclei. You can't appreciate like no vesicular looking nuclei, which is usually we see in ductal adenocarcinoma. So here the nuclei are clumped with salt and pepper chromatin. Cytoplasm is scant. Again, monotonous, round to oval. So neuroendocrine tumor is top on the differential. We did CK, A1, A3, a cocktail cytokeratin stain, and it shows a very beautiful expression of cytoplasmic staining. Because the cytoplasm is scant in neuroendocrine tumors, that's why you are getting this punctate and like a patchy staining of cytokeratin. And the chromogranin was also positive. We did another extended immunos also, like beta-catenin is negative, synaptophysin positive. Ki was also done, and the well-differentiated neuroendocrine tumor is diagnosed, is the correct diagnosis for this case. We are calling it well-differentiated because the morphology is not of small cell or large cell carcinoma. We don't see that brisk mitosis or apoptosis, and Ki was also within the like less than 20%. And in this case, I think just 1.5%. So well-differentiated neuroendocrine tumor after ductal adenocarcinoma is the second most common tumor in pancreas. And you can find a sporadic tumor or associated with some syndromes like MEN1, von Hippel-Lindau, neurofibromatosis 1, tuberous sclerosis. These are some common syndromes in which the chances of developing well-differentiated neuroendocrine tumor is increased in pancreas or in other endocrine organs in the body. So grading is very important in neuroendocrine tumor, correct and accurate grading, because prognosis is primarily dependent on the grade. As per new WHO, the most recent 2019, although we are expecting another edition at the end of this year, GI WHO, but as per 2019 edition, this is the grading system we used. So WHO grade 1 neuroendocrine tumor shows less than 2% mitosis and Ki less than 3%. Grade 2 are 2 to 20 mitosis and 3 to 20 Ki. And grade 3 is more than 20 mitosis and Ki also more than 20. So still we consider grade 3 neuroendocrine tumor as a tumor. We don't call it carcinoma. And to count Ki67, like just eyeballing is not at all sufficient. Try to count like 500 cells and then count your positive Ki expression in the 500 cell and get the percentage. And like this should be accurate as much as possible. So I'm also like printing my micro photograph for that Ki67 stain slide and manually like cutting all the 500 cells, counting and then cutting out the positive Ki67 and calculating the percentage. Radiology is also, again, very helpful and very sensitive in neuroendocrine tumors, especially the gallium PET scans. In MDT, I found it very useful, and it's like reassuring for the physician and surgeon as well. Sometimes we are getting very scanty material. It's difficult to give a confident diagnosis because there are normal neuroendocrine cells also present, or islet cell hyperplasia also part of a pancreas or chronic pancreatitis process. So if we have a very suboptimal biopsy, USFNA biopsy, these additional information through from radiology department is very helpful, because neuroendocrine tumor are gallium sensitive tumors. Just a macro photograph, cut up picture. So this is a neuroendocrine tumor of a tail of pancreas. You can identify this residual normal pancreas. Lobulated architecture even can be appreciated macroscopically. So main tumor here and few enlarged and likely metastatic lymph nodes in peripancreatic and the splenic hilum. And this is spleen, which is normal. Because of the combined vascular supply for distal pancreatectomy, you have to excise spleen as well. So a little bit about well-differentiated neuroendocrine tumor. You can see various patterns in this entity: solid, trabecular, gyriform arrangement, cords, ribbon, glandular, and tubuloacinar arrangement. So usually the tumor cells are small to medium size with scant to moderate amount of cytoplasm, uniform nuclei, salt and pepper, stipple chromatin, and inconspicuous nucleoli. They are rich in vascular supply. You can find sometimes amyloid deposition in insulinoma, some OMA bodies in somatostatinoma. Neuroendocrine tumor can be secretory or non-secretory. Secretory tumors are more common with syndromic neuroendocrine tumor. If patient have, like, suppose MEN1 and develop neuroendocrine tumor, the chances of having a secretory neuroendocrine tumor which secrete one or two peptides are more common. While the sporadic neuroendocrine tumor are generally non-secretory. And depending upon their secretions, patient have the relevant symptoms as well. So some OMA bodies can be found in somatostatinomas, and haline globules can also be there. So you can have various morphological pattern for neuroendocrine tumor. It's not just a simple morphology. One picture is enough to pick up the diagnosis. You can, like, you will be dealing with various patterns sometime, and it's difficult to come to the conclusive and correct diagnosis. CKI, as I showed you earlier, it shows Apache positivity, but it's a characteristic cytoplasmic staining is there. And the neuroendocrine marker, the recent marker is INS-MI1. It's very sensitive, more specific marker for neuroendocrine tumor. The previous one, still they are also very helpful. Chromogranin, synaptophysin, and CD56. And these are some secretory peptides you can apply on the FNB specimen or on the resection specimen. It's totally dependent upon the lab protocol or the gastroenterologist requirement. So case 4, yeah, a female patient and relatively young age, and there is a pancreatic mass, and this is the FNB material we got from this patient. So you can appreciate no normal pancreas. So it's reassuring that, okay, we are dealing with some tumor here and the lesional cells are here. Yeah, my diagnostic fear is always giving a non-diagnostic biopsy. You know, EUSFN, it's a bit complicated process. It's not, it cannot be easily booked again and again. Patient are going through sedation and all that process. So having a diagnostic material and enough material to work up and reach to the conclusion is very important. So there are neoplastic tumor present in low power. It's reassuring. Some GI contaminant. So the lumen they are using, the gastroenterologist, either they are approaching through stomach or duodenum. It all dependent that you can get the material from that wall, because they are puncturing the gastric wall or duodenal wall and then coming to the pancreas. It's a retroperitoneal organ deep-seated in the abdomen. So here we have some duodenal mucosa. You should be aware of this pitfall that you might be expecting a normal GI contaminant epithelium in EUS-FNB. So there are some tumor cells here, again, blood, some tumor cells here, some organoid patterns, and most of the tumor looks like a discohesive. Yeah, more further high power. So you have a vessel and the tumor cells are arranged around this vessel, forming some papillary arrangement. Again, discohesive cell, maybe some necrosis, some tubercular arrangement, and again, tumor cells here and there. Relatively monotonous looking. You won't be appreciate like a significant pleomorphism. Nuclei are similar to their neighborhood cells. And some myxoid change also around this papilla, this vascular papilla, and the tumor cell shows some grooving also you can appreciate in some of the nucleola, in nuclei. And some haline globules here and there. So young female with this morphology, solid pseudopapillary tumor is top of the list and should be worked out first. So we also did the same thing. Beta-catenin, nuclear staining of beta-catenin is considered positive. Membranous staining is a negative expression. So we did beta-catenin in this tumor and it shows nice nuclear positivity. CD99 is very very characteristic and show a very specific dot-like positivity in solid pseudopapillary tumor. I found this stain very helpful in diagnosing solid pseudopapillary tumor. Because we have scanty material in cell block, we can't throw like tens and tens or hundreds of immunos. We have to prioritize, okay, which immuno should be done first, and which is the most relevant immuno to be done on this material, because later on we want to preserve cell block material for the molecular studies. So beta-catenin and CD99 shows characteristic expression and positivity, which is like helpful for us to come to the conclusion. And this is a solid pseudopapillary neoplasm. In previous WHO, it was like considered as a benignish tumor, but in new WHO, it's included in a malignant tumor chapters. So it's a low malignant potential tumor with unclear cell of origin, usually present in younger female, most common in tail and body, but you can find this tumor in male patient as well in a rare instance. So usually present as a solid cystic mixed tumor radiologically and clinically. Morphology, as I told you on the slide, papillary fronts, myxoid hyalinized vascular stalk, lined by poorly cohesive. The cells disintegrate and like fall easily, and they spread easily on the smear slides or even on the cell block. Uniformity in nuclear grooves are again a helpful feature to come up with this diagnosis. Beta-catenin, E-cadherin, vimentin, CD10, SOX11, these are all positive stains. And you can like apply 2 or 3 to begin with. And if they are positive with other negative stains, you are okay to diagnose. I think we are okay to diagnose this entity confidently. Chromogranin should be negative in this tumor. So there are other neuroendocrine like CD56 can show a positivity, and synaptophysin can show positivity in solid pseudopapillary tumor, but chromogranin is must be a negative stain in this entity. Case 5, male with history of nephrectomy. I think with this history and with this slide, the diagnosis is really like spot on. It's a metastatic RCC, renal cell carcinoma. Always like in your, always keep this entity in back of your mind. If you know the previous history of RCC or nephrectomy, and even if there is no history, if you see any clear cell tumor in pancreas, you must rule out RCC, metastatic RCC. Maybe there is a small tumor sitting in the kidney and physicians are not aware of it, and patient present upfront with the metastatic disease. So in this case, we have the history and we have the characteristic morphology, clear cells, small nuclei, abundant clear cytoplasm, rich vascular structure. Yeah, very characteristic. All the diagnostic features of clear cell RCC, renal cell carcinoma are there. So just to confirm, CD10 is diffusely positive and PAX8 is also diffusely positive. So it's reassuring. And it's a case of metastatic clear cell renal cell carcinoma. Case 6. Yeah. So yeah, there are many benign entities also in pancreas. So we must be aware of that also. Female patient, solid cystic, well demarcated lesion in pancreas. And this is the material we got. Abundant keratin debris here and there. So the EUSFN approach either through stomach or duodenum. It's never be approached like for pancreatic lesion, I mean. So there is no esophageal approach for pancreas. So this can't be a contaminant epithelium. And having so much keratin with this mature squamous epithelium with underlying lymphocytic aggregates. If I show you the low power view, this is the whole slide we got, whole material. So you can appreciate it, like loads of keratin here and there, and with these tissue fragments, all these 3 tissue fragments showing the same pattern, mature squamous epithelium with underlying lymphocytic infiltrate. So it's reassuring that we are in the lesion and this is the lesional tissue. and we called it lymphoepithelial cyst. Again, an uncommon benign entity, but you can have it in pancreas. I think lymphoepithelial cysts are more common in head and neck, but you can have it in pancreas as well. Non-neoplastic, but malignancy can arise from it, like squamous cell carcinoma or any lymphoma. So it's more common in, like, you can have an extra pancreatic lymphoepithelial cyst as well, or within the body, head and tail. Hypothesis or like pathogenesis is not clear. There are some theories like it might be arising from an intrapancreatic lymph node or squamous metaplasia of pancreatic duct or misplaced branchial cleft during embryogenesis. These are some hypotheses for this entity, how it arises from pancreas. It can be from small to like huge in size. 17 cm cases are also reported, even benign, but it can grow immensely in pancreas and and become symptomatic. But circumscription and the well demarcation is always remain the rule. It can't be an infiltrative thing. If it is like, it means somewhere a malignancy have arisen from that lymphoepithelial cyst. Can be unilocular or multilocular, and you have this cheesy material and the keratin debris within the lumen. This picture I took from the intranet. So pancreatic tissue, and this is a lymphoepithelial cyst. Case 7. So yeah, I'm starting with the cytology prep slide. Yeah, dilated duct, but no solid mass in pancreas, and 74 age. And we got the smear slides. And this is Jimza stain. So you can appreciate there is a mucin deposit, thick kind of mucin here, and few big ductal clusters. It can't be normal, too much cellular, and cellularity is much more than a normal ductal group. They're hypercellular, they are large in size. Ductal cells are overlapping with each other significantly. They are not regarding each other boundaries. And there is like mild pleomorphism, or you can call it mild atypia. The nuclei are slightly enlarged. They are not like normal. There is no normal NC ratio. The NC ratio is disturbed in most of these ductal cells. And we got some tiny material from the same material in the cell block and PAP slide. Diff-Quick stain or the Jimza stain is best to assess the architecture. And architecture assessment is equally important in cytological preparations and for on-site adequacy. But to assess the nuclear feature, PAP stain is the best stain. So this is the PAP stain, and here you can also appreciate that there is a mild atypia, some nuclear rounding here, and there's some overlapping. Few are like still maintaining their polarity, but something going on. It doesn't look like a normal thing. And considering the dilated duct, there is a like clinical impression and clinical differential diagnosis of IPMN or MCN. Because the patient is male, MCN is slightly lower in differential diagnosis. So IPN is the most likely diagnosis in this case. And this is again the PAP stain. You can see some lymphocyte on the background, some foamy histiocytes, and these small discohesive cells. So the cell break down easily, the more they become dysplastic. The broad groups, thick groups are low-grade dysplastic, and if they are dissociate more easily into smaller groups with definitely NC ratio and pleomorphism, it means that the dysplasia and the invasion is likely to be happen in that tumor. So we have the small groups with dense chromatin changes. Again, these pleomorphic cells, again, you can see, you can appreciate mucin in the cytoplasm, some signet type arrangement, bizarre cells. So yeah, this one is also very like very dirty chromatin, or maybe some mitosis also there, and a very bizarre looking cell here. So neoplastic mucinous cyst, we called it neoplastic mucinous cyst on cytology smears or on a very limited material on FNB. You can't differentiate IPMN with MCN. So we use this umbrella terminology of neoplastic mucinous cyst because mucin is there, dysplastic cells is there. In fact, high-grade dysplastic cells are there. So we called it a neoplastic mucinous cyst, and we raised both differential diagnoses because rarely you can encounter MCN in male patient as well. So likely chances that it's an IPMN with high-grade dysplasia and might be invasive, a small component or invasive carcinoma also sitting with IPMN. IPMN are grossly visible, non-invasive mucinous epithelial precursor lesion, basically. But the chances of arising of invasive carcinoma from IPMN is significantly higher. You can have low-grade dysplasia in it or high-grade dysplasia. As I mentioned, like 33% of cases can have invasive carcinoma. And they arise from IPMN or associated with IPMN. So there are some morphological subtypes of IPMN. You can have gastric phenotype, intestinal phenotype, or pancreatic biliary phenotype. I think now the oncocytic type is a separate entity now. You can have like clinically, radiologically, you have a characteristic CT or MRI scan details if the main branch is involved or the side branch is involved. And you can even do KRAS GNAS mutation studies on the cyst fluid analysis. I think it's PCR sort of testing on that. So MCN, a little bit about MCN, benign, but potentially they have potential to transform into a malignant tumor. You can have a MCN with low-grade dysplasia, high-grade dysplasia, or invasive carcinoma. So again, a 3-tier classification for that. But the presence of intracytoplasmic mucin is a mandatory feature, along with like ovarian type stroma. So this is a macro picture of an MCN, cystic neoplasm. Don't have any solid component, and a separate duct is normal. Main branch duct is normal. So most common, MCN more common in 95% like in female, but there are chances like 5% cases are arising in males. Relatively, these tumors usually present and relatively at young age, can have similar phenotype like intestinal, pseudopyloric, gastric foveolar type, or pancreatobiliary type, and you have characteristic ovarian stroma present. Which you can, if you are lucky, you can have that ovarian stroma in FNB. Otherwise, it's very rare to get it. On resection specimen, definitely, it's easy to find it and do the confirmatory marker ER or CD10 to confirm ovarian type stroma. Yeah, just a resection specimen, MCN. So you have mucinous-rich epithelium on the top. So MCN by default have low-grade dysplasia. And then this accentuated stromal cells here are this is the ovarian type stroma. And if you throw ER or CD10 or inhibin this ovarian stromal marker, these all cells will light up easily and helpful for us to confirm our diagnosis. So I think this is our last case now. Yeah, we have a little bit time for the question answer session. Again, just a last case to show you again a pancreatic ductal adenocarcinoma, because this is the most common entity. And although it's most common, but it's not easy to diagnose in most of the US specimen. Pancreatic ductal carcinoma are a stroma-rich tumor. You can have a lot of stroma with few ductal infiltration. So if you are getting like, suppose if you get just this material on your FNB slide, you can't diagnose it. At the end, you will call it a non-diagnostic, although it's a part of tumor. So it's not every time, it's not an operator-dependent deficiency. It's the inherent morphological pattern of tumor that it's a stroma-rich tumor. But we need to confirm the diagnosis. We need to see naked, atypical, infiltrating ducts without with loss of lobular architecture. So mandatory feature is infiltrative ducts. They should show atypia. There is loss of lobular architecture and the desmoplastic changes. So very well differentiated tumor. You can identify very minimal atypia, but all the other features are helpful to make an accurate and correct diagnosis. You can appreciate how well differentiated this tumor is. But the desmoplastic change, loss of lobular architecture, clinical information, radiological information is helpful. We have PAP slide also in this case. Again, well differentiated. Maybe these are just a GI contaminant epithelium, monolayered sheath with the ample cytoplasm. But these are the tumor foci which show, and maybe discohesive cells, if you can appreciate these cells. They show like very irregular nuclear membrane. NC ratio is disturbed. They are discohesive, easily broken down from the tumor, some overlapping here, some pleomorphic cells here. So considering all the features, we are happy to call it pancreatic ductal adenocarcinoma. It's not mandatory to give a well or moderate or poorly differentiation on EUS. I think this is beyond the limitation of this limited diagnostic material. The differentiation we can give for the resection specimen. So it's pancreatic ductal adenocarcinoma case again. And thank you so much. It's all from my side. So if any question, I'm happy to take questions. I'm happy to take answers.
Well, thank you very much, Sidra, for an excellent talk and showing the value of pancreatic EUS. I mean, it's just incredible the range of diagnoses that you're able to achieve with such limited material.
Yeah.
Really, really impressive. I know one thing in the chat, we've had a question for, could the slides be shared on email? So, Charlie, I know that you should be able, I think Lydia and Ava have said that we are able to email out things to the participants. Is that correct?
Yeah, that's correct.
Yeah,
Yeah,
so
I'm happy to share. Yeah, no problem. Yeah.
Yeah, so Sidra, if you're able to send these slides to me and then I'll pass them on to Charlie, that might be the easiest way. Is that okay?
Yeah, that's fine. Yeah, I'll do
Yeah.
that. Yeah.
So yes, so in answer to that question, yes, we're able to share the slides, and the recording will be made available on the Diagnexia platform in due course. Are there any other questions from the audience? An excellent talk, really.
Thank you so much.
Yeah. Any questions? It was very well attended. Saw 33, and I know that in fact it's usually higher than that in actual life. Any questions from anyone? So I've got a question. So how often with these samples do you have to declare it inadequate, or because some of the samples you presented were really, there weren't a lot of cells there, and yet you were able to make a diagnosis. So in what sense? Yeah. So what percentage do you think they are really inadequate, and are there particular diagnoses that even with very limited material you can make a diagnosis?
Yeah, so I think percentage is still significant. Like it's about like 10 to 15% of our cases, they are non-diagnostic. Sometimes what we get, it's just the fibrosis and necrosis. We know that this is a material from lesion. We can see fibrinoid necrosis, but that material is not enough to come to like make any diagnosis. So like I think it's 15%, and I saw some cases like even on 4th EUSFNA, we got the lesional material. Sometimes we have to do like repeated EUS to reach to the diagnosis. But for me personally, like 15% still a significant percentage. And we can reduce that percentage if like in a state of like in ideal situation, if you provide a ROSE, rapid on-site adequacy facilities. So that will definitely reduce your inadequate sample percentage. And it all depends upon the staffing and like availability of resources.
As they do for bronchial.
Exactly. Yeah, somehow like we have, unfortunately, we are not providing ROSE services for EUSFNA here. But where I was trained, it was mandatory like even the trainee doctor or a fellow doctor is going to attend that EUSFNA within the endoscopy suite, and they are giving diagnosis or like at least the confirmation of an adequate material there. And they provide details for triaging, because if on rapid on-site adequacy you are suspecting a granulomatous inflammation or a lymphoma, you can ask for a flow cytometry or a cell block material, or like for TB PCR material, you can triage and you can get the material there and then, and let the endoscopist know.
Okay.
Yeah.
Another question: can we differentiate chronic pancreatitis from ductal CA on FNA?
Yeah, ideally, we should be able to differentiate in a chronic pancreatitis. The lobular architecture is preserved. You will see a lot of fibrosis, stromal changes, very reactive mild atypia in the ducts, but the SNI and the lobular architecture will remain intact. If you are getting that like chronic pancreatitis sitting just next to the tumor or ductal adenocarcinoma, then sometimes it's difficult to differentiate both things from each other. You are getting a bits of adenocarcinoma and a bits of chronic pancreatitis, and they are so intermingled with each other. You can't give a conclusive diagnosis, a confident diagnosis on that. In that situation, we are mostly calling it atypical, describing everything, and we ask for a repeat. Because, the consequences of giving a malignant diagnosis, it's a Whipple procedure. It's an extensive, a big surgery with a lot of comorbidities. So we have to be sure that we are dealing with the adenocarcinoma. So if we are not sure, we call it atypical.
So also with regards to that, you've got cases where you just get necrosis and fibrin. In an MDT setting, is that sometimes used to say, well, based on the imaging, the clinical features, and yes, it's not a completely adequate sample, but it has got necrosis and fibrin in it, that is sufficient for a carcinoma diagnosis or not?
No, this is not sufficient. It's mean nothing for them. And even nothing for us. Yeah, it has, that definitely has to be repeated. Oncologist, surgeon, you can have like necrosis in granulomatous inflammation as well, with lymphomas, with lymphomas as well. Lymphomas are not surgical disease, so it's mean nothing for them. Yeah, it has to be repeated.
Okay, thank you. I've got another question. How do you differentiate metastasis from colon, or biliary tree or liver?
Yeah, so metastasis from liver and colon can be differentiated, but biliary tree and pancreas, this is the same track. You can't differentiate like gallbladder metastasis in pancreas. There is no differentiating immuno available. But for colonic metastasis, which is slightly rare but can happen, SAT-B2 and CDX2 are useful immunomarker. Morphology is also like characteristic. It's a columnar type cells. And for the what other metastasis they asked? Yeah, liver. Liver also have a characteristic immunopanel. For hepatocellular carcinoma, you can do HepAR1, arginase, glypican-3, glutamine synthetase. These are some promising marker to confirm hepatocellular carcinoma metastasis in pancreas.
Okay, thank you very much. Any other questions? We're kind of up to the hour now, and I know Sidra has. Oh yes, I've got another question. I had a metastasis in the liver. My suspects are it comes from biliary tract or colon. Okay, so without immunos, you don't think that it's possible to distinguish between those, do you? Between colon or biliary tract?
Biliary tract, you can't. Biliary tract, it's a part of pancreas as well. There is a common bile duct coming into the pancreas, or the gallbladder tumor. If it's coming, you cannot differentiate. Even with immunos, you can't differentiate.
Okay.
Yeah, hepatocellular and colonic, you can get some clues on morphology alone.
Okay.
Yeah, with known history, okay, this is you can give a a bit like I must say a confident diagnosis if it's a well-differentiated hepatocellular or a characteristic colorectal adenocarcinoma, but I should advise immuno should be done for confirmation.
Okay. Any other one last question? No. If not, thank you very much, Sidra, for an excellent talk and really well prepared material and cases illustrating very wide range and showing the value of EUS FNAs. I think obviously it requires, I think in a resource poor setting, I think that this is probably a good approach because obviously it avoids biopsy in a very risky area. So
yeah.
hopefully with a decent endoscopy service, it can be done. Is that correct? Or does it require? Yeah.
Correct.
Okay. Well, thank you very much. And you've brought the academic year to a close. So thank you very much for that. And everyone, there is now a summer break in the UK. So we will be having a 4-week break and recommencing on the 3rd of September. So please don't forget us. It will be the same weekly presentations, alternating HemePath with external speakers. As I've said before, the HemePath will be starting to split into Trephin's, alternating each fortnight with lymphomas. And the external speakers, we already have external speakers booked in to the end of April 2026. So we've nearly completed the academic program for next year as well. We will do fill in the gaps from April to the end of July quite soon, I think. So remains for me to thank Sidra and all the speakers this academic year and the support of Diagnexia, particularly Lydia and Ava and Charlie and our colleagues and the entire Diagnexia supporting this program. And also thank you to you all for your continued interest. Program would be nothing without you. And please remember to freely share it with your colleagues so that we can build this community even more.